Evening, everyone. Hello, how's everyone doing?
Good.
Good. How are you, Dr. Shane?
Great.
You think we should wait 2 more minutes? Probably get a couple more people. I think 17 people is good, but let's wait for 2 more people, 3 more people, and it will start. We want to miss Dr. Holliday's nice talk, so let's let everybody get ready. Is that okay with everyone?
Yeah, sounds good.
That's good.
Great. Okay, good evening, everyone. We're going to get started. Aaron, are you there? Hello? Aaron, are you there?
Yes, I am. I'm at work, but I had
Okay,
internet
great.
issues. So I had to sign on
Okay,
to my
you're
phone.
recording this?
Yes, it's been
No
recorded.
problem. Welcome to this Cancer Society monthly meeting for February. May want to know why we're doing cervical cancer in February, although cervical cancer is celebrated in January. But we normally start the year off with a little motivational talk and pep talk at the Cancer Society. So we usually have the cervical cancer talk in February. And tonight we have Dr. Holliday, who is a gynecological oncologist specializing in gynecological cancers, both at the Princess Margaret and the Doctors Hospital. And he's gonna give us a talk tonight on cervical cancer. I think he's gonna touch on some of the advances in screening and what's new out there in terms of treatment for cervical cancer. But we'll let Dr. Holliday start his presentation. Dr. Holliday?
Good night, everyone. Certainly want to
You sound distant.
Oh, that's better?
Yeah, that's better.
Okay, thank you.
Good. Okay.
Okay, thank you for the members of the organizing committee for inviting me to give this lecture with respect to cervical cancer. It's something that we take for granted, but too often we see it where young women die, and this is a totally preventable disease. So we get very concerned when we see our young mothers die. When I started my postgraduate training, the teaching was that the annual incidence of cervical cancer was approximately 450,000 cases annually worldwide. And we can see from the new data that is now over 600,000 new cases annually. So the incidence is going up for a preventable disease, which means that every 3 minutes, a woman dies from cervical cancer. And this is pretty disturbing, and the majority of it occurs in the developing world. And it's one of the top global cancers, behind breast, colorectal, and lung cancer. But the significance is severe because of its economic impact. We live in what we call a high incidence region where the rates are between 16 to 25 cases per 100,000. When we compare this to North America and Australia, and many parts of Europe where the cases are 7 per 100,000 or less, we see that we have a lot of work to do. And prevention is indeed better than cure, because in our region, and this is old data now, in our region, in Latin America and the Caribbean, we have a loss of productivity of $3.3 billion per year. If women can't work, they have to take time off from work. The government have to subsidize their income, take care of their families, plus the cost of treatment. So is by no means something that we should be taken for granted. And cervical cancer lends itself for early treatment because it has what we call a long natural history, where even after exposure, it takes about 1 to 2 years for you to develop an abnormal pap smear after being exposed to the HPV, but it takes as much as 10 years after that initial abnormal pap smear to develop cervical cancer. So it means that if we involve ourselves, or if all our patients avail themselves to early screening methods, then this disease could be prevented. Now, the peak incidence is after the age of 30, because that's when the incidence of precancerous disease begin to rise. So we know that young women are susceptible to the human papillomavirus infection. There are multiple high-risk types which are associated with cancer, but the majority of people can clear these infections on their own. A small group, about 10%, have persistent HPV infections, and these are the ones who are at risk for cancer. And we'll explore some of that in the new guidelines. So because the incidence of persistent HPV infection is greater from the age of 30, even though that's not the peak incidence of HPV infection, it's the peak incidence of persistent disease. At that point, we see that persistent or pre-invasive disease and cancer begin to rise globally, when women are about 30 years old. So this is in the consideration of the WHO's new three-prong approach to prevention. So we're now advocating primary prevention, where girls and boys, as they did in Australia, start their vaccination from 9 to 14 years. Now, at the time of the initial studies, the recommendation was that we get 3 vaccines at 0 months, 2 months, and 6 months. But there's a lot of data to show now that 2 vaccines are as good as 3 vaccines, and at 0 months and at 6 months. And this is very important for us in developing countries, because it means our health dollars and our resources can be stretched further to cover a greater part of the population. And then we need to educate our young people about high-risk sexual behaviors, healthy habits, tobacco use, because tobacco is a carcinogen, and in particular in cervical cancer, because it suppresses the local immune response. And we need to advocate for circumcision, because it prevents the transmission of HPV and other types of ulcerative STIs, which put women at risk for cervical cancer. Now, in terms of secondary prevention, so primary prevention has to do with prevention of the infection and any pre-invasive disease. Secondary prevention is what we used to. That's the pap smears and the pap smear campaigns, which the Cancer Society has been a great part of for a long time. So the traditional model is we do pap smears. When we see something abnormal, we refer them on to get treated by either biopsy or ablation. Biopsy with ablation, the biopsy determine what it is, and then ablation. And then the newer approach, now it's been established and the technology has developed in the last 20 years to do primary HPV testing, meaning we test for the virus that causes cervix cancer once every 5 years. That's the new model that's being proposed. Then in this model, the ideal is we do a HPV test from the age of 30 or more to, and if the virus is detected, then we can look right there and then with the microscope and do whatever treatment is appropriate. So this model lends itself to communities, especially our family island patients, where they'll have to travel back and forth to Nassau, and is used globally. In India, has been very successful, and other parts of the world. And HPV also lends itself for self-testing. In other words, the woman can do her swab at home and then take it to a healthcare provider and get the result, or even mail it in. And then tertiary prevention has to do with treatment of actual cancers. So we covered a lot of this, and we see that with vaccination, vaccination is essentially 100% effective against type-specific HPV. In other words, if the vaccine is against the type 16 and 18, the high risk type 16 and 18, 6 and 11, which is low risk types, that's the Gardasil, protect against those 4 variants. The low variants protect against genital warts, and the high risk types are involved in the transformation and cancer in up to 70% of the cases worldwide. So that's why the vaccine contains those. So there's Gardasil 9, which contain other serotypes, but these vaccines are very effective. And once they're in the general population, they're around 70 to 80%, depending on the region. But we see that if we can get our herd immunity up by better vaccine coverage, then we can have a meaningful impact, as did Australia. So Australia is one of the few countries where they consider cervical cancer eradicated, because from the onset of the availability of the vaccine, they have had aggressive campaigns to vaccinate the whole population, both boys and girls. And now their incidence of cervical cancer is certainly less than 7 per 100,000. And so they're considered one of the few places that have eradicated cervical cancer. Now, this is a more the technical things that we need to look for, where other portions of the vaccines are used in the production. So normally we use the vaccines are produced against the L1 portion of the capsule. So what they're looking at is cheaper methods. E. coli is a fairly common bacteria, so they're thinking about having E. coli used as the bacterial carrier to develop the vaccine. The L2 portion of the carrier of the capsule is constant among the viruses, is irrespective of strain. So that's another option. But all of these are being conceived and researched because the overall is to reduce costs so more women could be reached. Now we know that screening is effective, and Dr. Papanicolaou demonstrated in his lifetime that we can achieve a 50% reduction of cervical cancers in our region if a good screening program is implemented. And this has been demonstrated in the UK, that as the incidence of cancer goes down, as coverage goes up. However, good screening programs are complex because they need a physician, the lab. We need to get the results. Then if it's abnormal, we need to treat with colposcopies. And then it's very technical. And we see here in the Bahamas that even though pap smears have been very available, and the Cancer Society does, especially before COVID, we had screening campaigns in all the family islands, and in Nassau, we still screen only between 10 to 15% of women eligible to be screened, and this is a problem. And very few countries in our region have been able to achieve screening rates of more than 20%. Only Bermuda, which is fully socialized, have achieved the coverage necessary to see the decrease in the incidence of cervical cancer. And because it's so complex, it seems to be a moving target. We have a high rate of turnover of cytotechnologists at the Princess Margaret Hospital. You know, and certainly when I was training in Jamaica, the cytotechnologists, before they had finished their training, they already had jobs in the US. So there's a high demand field, and our region we're not able to keep them in the region. So there are other types of pap smear. We're used to the conventional pap, but we're also the liquid pap smear, which is more sensitive and specific and enable us to get a clearer picture to view under the microscope, because we're able to separate the cells. And there's primary HPV testing, which we mentioned, and all the big studies, the meta-analysis, which is a conglomeration of all the studies and an analysis of multiple studies that's shown that the HPV testing is more sensitive and more specific than the pap smear. So in other words, it's a better test. And because it's done by a machine and it could be automated, and we can potentially get the results usually within an hour if it's fully set up. The WHO has been pushing for that model because It allows for point of care treatment as opposed to our current models where we have to do call and recall, and our patients often don't avail themselves to follow up. So this is definitely the trend in the literature. Other models involve doing both a pap smear and HPV tests, and especially after the age of 30. So what are some of the current guidelines? So most authorities agree that from age 21 to 29, we should do the pap smear every 3 years. After the age of 30, we have the option to continue every 3 years with the pap smear. But if we do the HPV test as well, we could prolong the screening interval to 5 years. We call that co-testing. And women who are low risk after the age of 65, the guidelines suggest that they don't need to be tested, but your screening regime needs to be individualized between you and physician, because you've had a history of abnormal pap smears, you have immunosuppressive therapy, so it's as patients with HIV, people living with renal transplant or other disorders which require lifelong immunosuppression, such as SLE, then we need to continue our routine screening. Now, so this is just more to show that all these guidelines have been endorsed by multiple organizations. Now, if you had a hysterectomy for what we call benign disease, like you had fibroids, you never had abnormal pap smear before, then you would not necessarily need to follow up with your pap smear. But this doesn't negate the need for your annual examination by a physician to do a pelvic exam to determine whether or not there are other gynecological pathologies that need to be addressed. So these are some of the current guidelines. And so just to make you all aware, now the primary HPV testing, as we said, would be at the age of 30 years and older, and the hybrid capture, COBIS, they're all various methods used to do the testing. Unfortunately, we don't have HPV testing in the Caribbean. I mean, in the Bahamas as of this moment. We did at one point through the efforts of one of our retired cytopathologists, Dr. Stokes. She had lobbied with Rotary to donate a machine, and we were able to do the testing for several years, but the funding for that project ran out and she has retired. And then we have other technical challenges with the current equipment and reagents. And then of course, COVID, as you know, has taken the forefront nationally. But there are other biomarkers which are and stains that are used in the lab to help us determine what's going on better on a pap smear, such as P16 staining and so forth. But we won't go into that. Okay. Now, in countries where they can't even afford to do a pap smear, or they cannot afford to do HPV testing, and I have a good friend in Guyana, so for their national screening program, they do visual inspection with acetic acid, where they put the special stain on the cervix, check for any abnormalities. If there's anything abnormal, then the patient would have the appropriate treatment at that point. And that's also been shown to be very effective. Even one screening encounter in a woman's lifetime in a general population in their 30s have been shown to be effective in reducing the incidence in that region. So this is another method, and this is practiced in some of our Caribbean countries, which are falling on hard times. So, so a positive test, as we said, would stain white. If we use iodine, then the surrounding tissue would stain black and the abnormal areas would be white. Okay. And then we mentioned vaccination, and we know that the vaccine campaign is well established. We need to vaccine girls from the age of 9 to 26. There is also approved for women up to the age of 45, but is recommended that you have that discussion with your physician to evaluate your risk. But definitely fully recommended for women up to the age of 26 years. So with this model, the WHO hopes to achieve an accelerated plan towards the elimination of cervical cancer with a target goal of 4 cases per 100,000. So that seems like pie in the sky, but it could be achieved by 2030, especially if it were not for COVID, because we went to some of these conferences before the onset of COVID. And the idea is we have 90% of the target population vaccinated by 15 and 70% of our population screened. We expect a 30% reduction in mortality in cervical cancer. Okay, so this is how we undertake the screening. So just give me a moment so I could discuss and continue our discussion with respect to the presentations and some of the common presentations that we find in our societies. So in terms of the disease presentation, so we know that there are several types of cervical cancer, and they resemble the cell line of origin. There is squamous cell, there are adenocarcinoma, and of course they are mixed. This description is essentially regarding the appearance of the cancer with respect to the cells of origin. And the most common signs and presentation is in the early stages asymptomatic. In more advanced disease, we see that we can get an abnormal discharge. There is sometimes bleeding and bleeding after sex. In more advanced cases, the tumor would erode into the bladder. So pee might come to the vagina, or if it erodes posteriorly, stool may come into the vagina. And if it grows laterally, it'll block the kidneys and cause renal failure. It could spread all over the body and cause what we call constitutional symptoms of pain and weight loss and decreased appetite and shortness of breath and all those sorts of things. And we would find some of these, we'll find a gross fungating lesion, usually on clinical exam, in more advanced disease, or swelling of the leg when it blocks the drainage from the legs. And these symptoms are pretty debilitating, and they affect the women's quality of life greatly. They affect their interaction with their partner. If they're bleeding all the time, our Caribbean men, they have many needs, and they would seek to have them satisfied elsewhere. So it wreaks havoc in our society and ruins relationship. And we investigate according to the stage of the disease. So in early stage, we would do a biopsy um, to remove all the abnormal areas. When a woman gets an abnormal pap smear, the first thing we often do, or any abnormal screening test, we would do something what we call colposcopy, where we look with a microscope to highlight those abnormal areas, then we'll do a biopsy. If it's a high-grade lesion, we would treat that with either excising it, or we'll freeze it, or we would do some thermal ablation or laser ablation to destroy those lesions. And then we'll follow up with the pap smear. Now, if there is a cancer detected, then we would do blood tests to, especially if they have symptoms of weakness. Then we'll check the kidneys by doing what we call a pyelogram or ultrasound. And then we do a CT scan to get the extent of the spread, or we could look in the blood and look in the rectum. And once we determine the extent of the spread of disease, based on these tests or MRI or PET scan, then we can determine the stage. So traditionally, cervical cancer has been clinically staged, but now we allow for radiological and pathological findings to influence or the stage of the patient. So simply put, early stage disease is confined to the cervix, whereas more advanced disease spread beyond the cervix. So stage 1 disease is confined to the cervix. Stage 2 disease spread to the vagina and the tissue next to the vagina. Stage 3 disease spread to what we call the parametrium, so it's closer to the side wall and in the lower vagina. And stage 4 disease, the tissue erode into the vagina or rectum and as distant spread. Now, the treatment is either surgical or radiotherapy. So in early stage disease, surgery would suffice. If it's just a small lesion on the cervix, if you remove the cervix, that would be all that's required. In more advanced disease, then we'll have to do a hysterectomy, or what we call a radical hysterectomy, where we remove the uterus and the tissue next to the uterus and sample the glands with the aim of getting a cure. And if the lesion is more than 4 centimeters, then we'll refer those patients for radiation and chemotherapy. And these are based on standard algorithms that have been described over the years. And finally, in even more advanced disease, then we'll have to engage the patient in traditional chemotherapy. Okay, so we'll skip these slides and say and go to the end, because basically in advanced disease and in recurrent disease, what we promote is chemotherapy, because that's what we have. We traditionally use cytotoxic agents such as Taxol and carboplatin. A lot of data has shown that we could add Avastin, which is a anti-angiogenic drug. But what has been very exciting in the last few years is the development of immune therapy, where we stimulate the body's natural defenses and the white cells, the killer T cells, to fight against the cancer. And for that, we use agents such as Keytruda. And these agents, while they're pretty effective, they come at a very steep price, and the average patient is just out of reach for them in terms of their ability to afford these treatments. And they're not a lot of these treatments, as we said, in terms of the chemotherapy and the radiation, even though we know they'll work, they're not without the side effects. There is a nausea and vomiting. We can largely control that with medication. The chemotherapy would cause hair loss, bone pain. Sometimes it could be associated with loose stool as well, and candida, and neuropathy, that's numbness in the hands and the feet. And to endure all of that in the name of treatment for something that's preventable is pretty challenging for many women to conceptualize, and as young women, so we have to push these therapies hard. And then in terms of the radiation is not without its side effects. It too can cause fistulas, even though the rates are less than 10%. That's abnormal connection between the bowel and the bladder. Can cause hip fractures, can cause it can be associated with anemia as well. And it is associated with long-term and short-term effects such as radiation enteritis, and where the patient could have diarrhea and cystitis, and sometimes these can last many years after the treatment. And there's the possibility of secondary cancers. So it's not that I'm trying to highlight the negative effects of the treatment, but this is just to emphasize that a pound of cure does not do as well as an ounce of prevention. So even though we still have a persistent global problem, we need to advocate for prevention through vaccination and through screening, because as the previous slide shows, for early stage disease, we could get a cure. If we catch it in the pre-invasive disease, most women would not have any problems for the rest of their life once appropriately treated. But in advanced stage disease, no matter what we do, despite our best efforts, survival is less than 10%. For stage 3 disease, half the women would die within the first year in spite of treatment. So we need to do our best. We need to get the word out. We need to tell it to everybody that prevention is better than cure. So thank you very much for listening, and we'll entertain questions at this time.
Anybody have any questions? I can ask a question. You said only about 10 to 15% of women actually get pap smears. Well, why do you think that is?
So that's a good question. So Dr. Riley Butler, everybody should know Dr. Butler. He did a survey, and there have been many surveys done globally where the reasons are simple. I mean, things like that they think it's uncomfortable. They don't want to take the time from work. They don't see the need for the pap smear when especially if they're feeling well. And it's mainly socioeconomic, where it's a matter of education. The women simply don't know, or they undervalue the importance of the test. And for a lot of our women, it's even we see it for all the other health issues that it's hard to get a day from work to
But
do
we
well
spoke
healthcare. Mhm.
about this new HPV testing. You think that will cause a change in terms of having persons screen? Because
Yes,
you
so
said
there
done at
was a
home,
mhm.
yeah. You said it'd be
So
done at home. It can be mailed in. So whether we should see that seek if that is a better plan than this pap smears, because if women are afraid to go to the physician when if they can do the test in their own home, then maybe they'd be more comfortable with that.
right, so that has been tried in Canada, especially in the northern tribes where they're sometimes landlocked with snow, and it's been done in other countries where when women miss their screening appointment, they've been mailed a kit to do the self-test, and they would send the kit back to the provider, and
Okay.
they will get their test done. And in countries where a mail-in self-kit is done, it's been shown to increase the screening rates by 70%. So that's something that we should definitely strive for in the Bahamas, especially during COVID time when
Expand
people are
on
afraid to go.
expand a little bit on the home testing. What does it entail? It's not really a pap smear. It's just a swab or endocervical swab. What is it?
Well, it's actually a vaginal swab. So
Vaginal?
yeah, so in those regions where it's done, there's a kit. There often is associated with an instructional pamphlet or video where the patient is asked to get in a relaxed position, and you swab the middle to the lower third of the vagina just with a Q-tip swab. And then there's a special collecting container, and once this container is deployed, or the sample is placed in the container, that could be mailed back to the provider. And there's good results have been noted with that. So, and the data also show that it doesn't have to be cervical swab, because we know that the HPV infects all of the genitalia. So it's associated, it's present in the vagina as well as the cervix. It can infect the vulva as well as the rectum. So it's a field effect.
I'm going to be devil's advocate. The new NHI medical system that we have now in the Bahamas. Do you know if pap smears are covered, and has it made any change in terms of percentage of women seeking to do pap smears?
Well, we are yet to perform the audit. So that's a extremely important question. We have yet to perform the audit in terms of who, in terms of the uptake of screening in the NHI. So the first phase of the NHI was to cover screening for the most important things. So I think they try to cover mammograms, they try to cover your blood tests for diabetes and all of that. And they do cover pap smears, which is critically. And then the second phase was to involve treatment for the common cancers and some of the other things, but that hasn't come to fruition as yet.
Okay. Does anybody else from the audience have any more questions? Because I could ask a few more, but I want to let people have a chance. While people are thinking about their questions, my concern now with COVID being around, you have a lot of vaccine hesitancy. Is the Gardasil vaccine part of the immunization protocol for our children? And if it is, how well has it been taken?
Okay, so that's another study yet to be done, but the uptake isn't what it should be. When it was initially rolled out, it was a part of the schools, but because of COVID, it went back into the community clinics. So it's available for or kids.
But it's not protocol. Like you get diphtheria, DPT, 3,
Well,
6.
it's still largely voluntary. So When
not
it's
man-
in, yeah, so, and it's not mandatory.
Mm,
So for example, in the schools, like they would write to the parents and say, well, we're coming to the vaccines on this day and that day. And if you want your kid to participate, you parents will sign the permission slip and the kids will be vaccinated. So it's an opt-in method of vaccination as opposed to opt out, where it's mandatory and you have to provide a written reason why the kids shouldn't get it. But it's available free of cost. The government of the Bahamas has gone through a lot of expense to procure the vaccine, especially in the first 2 years. And now it's on the PAHO, or the WHO revolving fund, is one of those vaccines that qualify for that. So the region is eligible for bulk purchases of the vaccine at a reduced cost, but it's available and the uptake is not what it should be. We did a survey many years ago which suggests that 70% of the parents would vaccinate their kids, but I don't think the uptake is more than 20%.
Are any countries mandating the Gardasil vaccine, or is it all voluntary?
I'm not too sure, but in a few Latin American countries, they're actually doing studies where they study one vaccine, and that has some benefit as opposed to the three we know. There have been studies on two vaccines. I know in some South American countries, when we went to the conference, they were hinting that they're trying to make the legislation to make it a part of the routine mandatory vaccine package, but I'm not sure to the extent to which that legislation is successful. And as you rightly said, there was a lot of pushback, especially in Trinidad, when the HPV vaccine was being rolled out, because people considered because HPV is transmitted sexually, the community pushback was trying to suggest that we are encouraging promiscuity with such a vaccine. Once the girls know that they're vaccinated and protected, they will go out and misbehave. But I mean, none of the data has shown that. But there is a perception and stereotype in the community which you have to overcome.
Yeah. Well, you pushed the word about screening and prevention, but you being a gynecological oncologist, you might see what percentage of early versus late disease.
Okay, so unfortunately in the Bahamas and in the Caribbean in general, because our screening rates are so low, the data suggests that 2/3 of all women would present with locally advanced disease, stage 3 and 4 disease, and half would die within the first year of diagnosis.
Yeah.
So I mean, so we should be doing more surgery and less chemotherapy and radiation. But the reality is the majority of all women are so advanced, we can't get to those curative types of treatment. We have to use chemotherapy and radiation. Much of the time is palliative, and in a few cases, we're able to treat with curative intent.
Yeah, because we get a lot of applications for financial assistance, and they want essentially that is just palliation really, and it's just expensive treatment. Unfortunately, that's the way it is. But we got to try and push more screening and catch these things a little earlier, But I guess we need to do more education of the public and push the screening and push the vaccine a bit more. But I think the vaccine might be a hard sell because our COVID vaccination is just only what 30% or more, so not even 40%. So that's going to be a hard sell. But people still present late, and then they want,
Yeah, so I
radiation.
push prevention in this presentation because, as you rightly said, there are many applications to the Cancer Society for treatment. This year, we've diagnosed the youngest person in the Bahamas I've met with cervical cancer was at 20. She was 23 at the time. Fortunately, she did okay. We've lost 28-year-olds. I've lost a 30-year-old late last year. We've lost two 30-something-year-olds. I'm young women. I could see their faces, and it breaks my heart because these were productive members of the society. By
But
and
if you
large, they had
a lot of
small children,
yeah.
and they'd lost. When we meet with the family to discuss the prognosis and the diagnosis and the outcome, it's heartbreaking and it's palpable.
It seems like if it's the same as breast cancer, we're seeing a lot of women getting breast cancer at a younger age, and most papers say. So if you're doing HPV testing from 30, you'll miss all these people.
Well, that's why I emphasize the hybrid measures. So we do pap smears from 21 to 30 to capture that age group. And the reason why we don't do HPV testing below the age of 30 is because the incidence of HPV is pretty high. We say everybody got it. 80% of the population is expected to acquire it during their lifetimes, with 10% to have persistent disease. So we worry about the 10% with persistent infection over the age of 30. That's where HPV testing has its best value. But below that age, we still have to push for cytology. So the model would probably end up being a hybrid.
One last question and I shut up. You said Dr. Stokes was doing HPV testing or no?
Yes.
So that machine that she got paid for by Rotary, is it still available, or you need special reagents to run tests on that machine?
Well, it fell into a state of disrepair.
Oh boy, okay.
And but because the technology had improved
After Dr. Lon died.
from the initial set of testing, in the initial, she was using hybrid capture, but the Optima, which can also be used to detect HPV test, the Optima test, which is used to check for gonorrhea and chlamydia.
He's Indian, or he's like,
and we have a machine that can do that, because we have to test the pregnant women for gonorrhea and chlamydia, and our teens and everybody else. That machine can also be used to test for HPV with the appropriate reagents and minor changes in the setup. So the hospital began to push for that, and we were doing that for a little while. But then, COVID has kind of pushed everything back. So we currently don't have any capacity to do any testing.
So the audience have any questions? Anything at all?
Okay, good evening.
Hello.
My age is 67. I've been doing pap smears for half of my life, early 40s. So what are your suggestions for me?
Well, that's a conversation you have with your healthcare provider, because we need to look at your screening history, your history of abnormal pap smears, and your particular risk. So in general, if you've never had an abnormal pap smear, then the teaching is that you can stop doing pap smears by the age of 65. That's what the literature suggests. But our population, for the most part, is under-screened. So the average patient would not have been perfectly screened, meaning had pap smear all their lives. So, we still encourage women, even over 65, to have smears until the provider is satisfied that they meet that criteria of being ideally screened. Now, what we still advocate, if you are the ideally screened patient and they don't do pap smears after the age of 65, you should still have an annual pelvic exam. Sometimes we feel masses that we may be able to address. And sometimes, even though you're not doing a pap smear, we may see another lesion that may need to be biopsied. So we still advocate that you would have an annual exam, including a pelvic examination. Okay.
Okay, thank you.
But go ahead.
Thank you.
Okay.
Any other questions? No more questions? Anything?
Dr. Holiday, you had said, sorry. You had mentioned about having a hysterectomy. Once you have a hysterectomy, you don't need to have any more cervical examination?
Okay, so it depends. So there are many types of hysterectomy. So you could have had a subtotal hysterectomy where they remove the top part of the uterus and your cervix is still present. You still need to do your pap smear. For those who've had a complete hysterectomy where they remove the body of the uterus and the cervix, if they had perfectly normal pap smears all their life before that time, then the teaching is you don't need to do a pap smear. Now, if you've had a history of HPV infection, or if you've had a history of abnormal pap smears that were treated, you still need to undergo some sort of screening in the vagina, because as we discussed, the HPV can live in the vagina as well. So even though the incidence of vaginal cancer is much less than cervical cancer, because the vagina is more resistant to neuroplastic transformation than the cervix. If you've had a history of abnormal abnormal smears, you've had radical surgery for cervical cancer without radiation and all that, then we would still advocate for pap smears. So it depends on the reason why the hysterectomy was done. So if you had it for non-cancerous and non-precancerous causes, and you've had a perfect pap record in terms of results and frequency of screening, then the teaching is that you don't need to do a pap smear.
Okay, thanks. What about endometriosis? Is that a part of cancer, or if somebody diagnosed with that, had surgery to remove it, do they have to do pap smears to see if it moved or advanced, or is it part of cancer, or is just something that it's
Okay, so technically, or strictly speaking, endometriosis is not cancerous. Okay, it is basically what we call ectopic or abnormal placement of the lining of the womb. So you have abnormal deposits in the belly. And if you have abnormal deposits within the muscle of the uterus, we call it adenomyosis. But it is not cancer. It tends to behave like cancer because it can spread to other parts of the body. But usually after a hysterectomy, especially when we remove the ovaries as well, because it's hormonally driven, meaning the estrogen that the ovaries produce would cause the endometriosis to proliferate. Once we remove the ovaries at the time of hysterectomy, then usually you don't have any other problems. So the short answer is that endometriosis is a benign condition. And if you had a hysterectomy for endometriosis with a perfect pap history, you don't need to do a pap smear.
okay, thanks.
Any other questions at all? Anything at all? Anybody?
Well, a comment. I find
Right.
that, speaking with other women, like Dr. Holliday said, they are uncomfortable, having someone examine them in such a way. Are there many like female gynecology oncologists that, they may be more comfortable with than with a man?
Yeah, that's a good question. So ironically, some of our patients prefer male gynecologists, and some would prefer female gynecologists. But the screening can be done by anybody. It can be done
The
by
GPs.
your general practitioner. You could done by the general gynecologist. In the Bahamas a long time ago, we used to have the midwives on the family islands doing all the pap smears. And many parts of the world that still advocated the nurses would do the pap smears. So it's not necessarily who does it, but in terms of, you don't have to have a super specialist to do a pap smear, but important thing is that person is appropriately trained, and they are able to do the pap smear and sample the appropriate areas.
That's
So
why I
with-
mentioned NHI, Aaron, because NHI has a bunch of physicians, mostly GPs, and a lot of them are women. So they can be doing the screening pap smears. So the women have now no excuse now. They can go to their GPs and get their pap smears done. And hopefully it will be covered by NHI at some point.
Yeah, it's covered. Pap smears are covered.
Covered, yeah.
Oh, awesome, awesome.
Are there
Yeah.
any questions? Well, Dr. Holliday, thank you. It's a very informative talk you gave, and I think we in general need to maybe highlight cervical cancer like breast cancer, and highlight like cervical and prostate cancer more like breast cancer. So I think going forward, the Cancer Society needs to probably do that more and push the powers that be that, one, we need more screening for the other types of cancers, not only breast cancer, because breast cancer does get a lot of media, but these other cancers definitely need improvement in terms of getting the message out, getting the people to do screening, and hopefully the rates will come down. Because we all see too many advanced disease in cervical cancer. I must mention, in terms of notices, there won't be any March meeting, no March educational meeting. In March, we'll have our annual general meeting, as usual. Not, I don't say as usual, but last 2 years, or last year, we had a Zoom AGM. The year previously, we did not have one. But this year, we're going to have an AGM, in-house AGM, for all those Family Island listeners there. So we're going to go back towards having an in-house AGM meeting, and hopefully persons from the Family Islands will come down and join us again. But in terms of announcements, I don't really have much announcements. Does anybody else have any announcements to make? Aaron, have any announcements?
Just our crazy dollar day sale. We had it last weekend on Friday and Saturday, February
Mhm.
5th and February 4th and 5th, and it's going to be held again this Friday and Saturday on the 11th and 12th. So it's going to be from, it's our thrift store,
Right.
thrift store. So they can come and partake. Those that may can't come out on Friday, they can surely come on Saturday and take advantage. We had quite a bit of nice stuff, and hopefully we supposed to have some donations of more stuff. So,
Yeah,
you
so
know,
listen,
come in and browse.
this is how they spread the word. We have a nice thrift shop that we have a lot of nice things that can be bought for little or no cost. Any other announcements? Okay, well, we call it an evening. Thank you again, Dr. Holliday.
You're welcome. Thank you.
Okay, thank you all for listening and attending. And we see you next time.
Good night, everyone.
All right, good night.
Good night.
Good night.